Couple of announcements for us to walk through. Everybody get the BB Learn announcement today, this morning? Okay, so you should be checking those on a regular basis because it gives you information about what's happening for the week. And it looks like some folks aren't here today. Maybe the wind scared them away. It's pretty windy out there. Or maybe it blew them away. But important to take a look at those BB Learn announcements. There's actually 2 quizzes this week. We're in 2 chapters. Okay, so we have quiz 9 and quiz 11. So I really want you to pay attention to that. Quiz 9 and quiz 11. Here's the reason it doesn't go sequential. Maybe you don't care. But textbook authors and professors don't necessarily always agree on the order. And I really think it's important, in my opinion, it's just my opinion, to cover nerve physiology all the way through. And then we get into muscle. Because you can't contract a muscle unless the nerve sends a signal. So that's why it's slightly out of sequence. So you're not going to get 10 until later. And you're doing 9 and 11 this week. Make sense? And so you're going to be hopping between peripheral nervous system and autonomic nervous system between chapters 9 and 11. Those 2 quizzes are not due until Sunday night at 11:59 p.m. And on the quizzes, the chapter quizzes, I've been telling a lot of you this, they really are supposed to be give me points if you do them. You read the chapter, even if you skim the chapter, you open the quiz, you should be able to answer those questions and get good scores. And we'll drop your 2 lowest chapter quizzes. So at the end of the semester, they're worth 100 points, and they're trying to help move your grade up. Okay, so don't blow them off. And you have a whole week, 6 days to get them done now. Right? So try not to wait to the end, because I know at the weekend it's tough to remember. And the reason it's 11:59 is so if you come back from out of town, you can go, oh crap, I forgot to take it, and you can still take it. And then the 2 freebies are because sometimes you wake up Monday morning, you're like, whoops, I forgot. But don't burn both freebies this weekend. Coming up, okay? Office hours. You guys see the office hours? So tomorrow I'm expanding office hours 10:30 to noon by Zoom. And then Wednesday is 10 to noon. And some of you that had institutionals are actually doing a makeup exam on Wednesday. So it's going to be a little crowded on Wednesday. If you can come on Tuesday Zoom, that would be great. Okay? But we'll try our best to manage the queue. Okay? All right. The last question I've been getting a lot is, okay, so Keller, did you enter our grade with the bonus on Exam 3? And the answer is no. Exam 3 grade is raw. Your bonus is a separate column. So you add those 2 together, and that's sort of your combo for that exam. Make sense? Because some of you ask, I get a lot of those questions. If you look at the grade book on BB Learn, and thanks to our TAs and SIs, we've gotten all updated. So I just want to let you know, because I've had some students ask, pretty nicely, like, hey, when are we going to get those quiz grades entered? There is not a great solution to get them from the GRL textbook platform to BB Learn, because we're moving to Canvas, and so they don't want to spend the energy. That's the collective they. Nobody wants to spend the energy making an algorithm. So literally they're hand-entered, and there's 350 of you. So it just takes a little time to do that, and then we had to double check and make sure. So if you see an error in your chapter quizzes, like you go to GRL gradebook and you're like, hey, wait a second, I got a 10 out of 10 on that quiz, not a 8 out of 10, just let us know, okay? Please don't be mean about it. Just, hey, we made a mistake. We might have misentered something. You with me? But those should all be inputted as well, the chapter quizzes. So BB Learn on the running total, not your midterm grade, because we've had more points since midterm, your running total point should be accurate as of today, unless you're doing a makeup on Wednesday with me. We good? I think it's going to be pretty windy for the next week or so. but no snow, so that's good. Smiles. See some smiles out there. Oh, that was a fake smile. Okay. What kind of fruit has the most electricity in it? What kind of fruit has the most electricity in it? A watermelon. Watermelon? Okay. What do you call the hair under a cow's nose? A moustache. Well done. What type of dinosaur does things really quickly? What kind of dinosaur does things really quickly? A velociraptor, is that what you said? Those are dangerous. This is a figurative, fictitious brontosaurus. All right. That's all I got. That's as good as it gets today, folks. Sorry. Obviously, stand-up is not in my future. Okay. So, we're into peripheral nervous system, chapters 9 and 11. I also made an announcement. I kind of updated these slides a little bit. Some of them, you'll see, are a little redundant. And it's intentional because some of this material, I think, at the end of last unit, before we got into the review session, that might have been like, oh man, I don't even remember much of that. And it's important. We're transitioning out of central nervous system. And in lab this week, you're actually going to be dissecting the brain. Okay? Sheep brain, smaller frontal lobe. Kind of make some observations between what we looked at in the last unit and what you're doing this week. But you should be well teed up and well prepared for the brain dissection. Like, you should know where most everything is. Right? We've covered most everything. What we didn't really cover were a lot of the cranial nerves, but you'll get into that. We're going to cover some of them today because they make a difference when we start looking at spinal nerves and as they take off out of the central nervous system into the periphery. And the periphery, the peripheral nervous system, the job of this peripheral nervous system is to really interact with our outside environment. So the idea here is we spent in last unit all this time in the central nervous system, and we packed into that nerve physiology. Okay? That's what we just came from. Now we're going to transition a little bit into the peripheral nervous system. Nerve physiology is still extremely relevant. In fact, when we get into muscle physiology, which will be next week, you're going to see some of the same principles of that action potential relevant at the muscle level. So I don't have to reteach it to you. Maybe I have to refresh it, and maybe there's some stuff you're like, oh, shoot, I actually still didn't get it after that exam. I really want to understand it. Well, come see me. Let's talk it through. But we'll take a lot of those motifs through into muscle physiology. Nerve physiology and muscle physiology are very intimately related. The central nervous system and the peripheral nervous system are very intimately related. These are autonomic neurons up here in the upper left of the enteric nervous system of the digestive tract. And we'll talk about the enteric nervous system today. After we cover the parasympathetic and the sympathetic, we'll cover the enteric, which is almost considered like its own nervous system. It operates where you've got GI motility of your gut that's happening right now as you're sitting here digesting the meal that you had for lunch or the snack that you had before you came to class. Or it's digesting you because you're super hungry and you're going to eat after class, right? And it's moving and it's gurgling and you're kind of embarrassed. This thing runs kind of independently, and we'll talk about that a little bit today. But the whole idea of this peripheral nervous system, whether it's autonomic or somatic, is to bring in information from our outside environment as well as our peripheral features like arms, limbs, gut, to the central core, which is the spinal cord, and then up to the major processing unit, which is the CPU or the brain. And so this is how we bring information in. It's also how we're going to extend information out. So if we look at this little roadmap of where we are and what we're studying, here's where we were. Nice and simple. Central nervous system, brain and spinal cord. Let me ask, does the brain and spinal cord know it's part of the CNS? No, it's just this label we've made for it. Because it's easier to make a flow diagram like this if we've compartmentalized and put labels on things. Does everything fit nicely into this? Not really. But for the most part, there's a few exceptions, and we'll talk about some of those. But for the most part, we're going to be over here in the peripheral nervous system, and things will follow either a sensory or a motor. They'll follow either a visceral or a somatic. When we get into visceral, and another name for that is autonomic nervous system. So visceral, autonomic nervous system, we'll look at sympathetic and parasympathetic divisions. Now, this is a little bit of a review. We covered this in the beginning of the semester. We covered a little bit in the last unit. But I wanted to give you this chart just so you can kind of see where we are and how we're going to cover this material. A little flow diagram is helpful. Now, if we look at our visceral motor system, it's extensive. Is this intended for you to memorize this chart? No. Am I going to have this image on the exam as one of the 3 or 5 images that flip at the end of the test? No. Okay? You might want to write that down. So it's like, don't worry about this studying this one. Because if you're noticing a strategy is the images that you see are things that we've covered in lecture, right? It's true to that statement of I write the exams off of the lecture material. So is it important that you know that the visceral motor system is also referred to as the autonomic nervous system? Yeah, that's an important piece of information to take from lecture. The other thing is, know that it's unconsciously controlled. It monitors a lot of these homeostatic mechanisms. Things like body temperature, digestion, heart rate, metabolism, breathing, urination, defecation, pupil diameter. We'll get in a video here on the mituration reflex today. And what you're going to start seeing is there are some basic functions of how the body operates, like the urge to urinate. And the normal, untrained state is if you have to urinate, you do. And what we do is we override that reflex because it's considered inappropriate to pee your chair. Okay, so you wait until you can go out into the lobby and go to the restroom. And that's a training process overriding this autonomic response. Okay, I could have used the defecation example, but that's a little bit more disgusting, so we'll just go with urination. All of these are controlled automatically or by the autonomic nervous system. And it's really important that it does, because many of these things need to happen when you're asleep. You still need to breathe. Your heart still needs to function. Metabolism needs to happen. Okay, what about the urination and defecation? Well, that is a interesting topic, and we'll get into the mituration reflex later in the lecture, okay? So all of these things need to happen when we're not consciously awake. We looked in the last lecture, in the last unit, over this motif in this diagram. I'm showing it once again because I want you to be able to appreciate some of these themes. And I hope what you'll understand is when I say the class is cumulative and 202 is cumulative, some of you are like, oh gosh, seriously? What you'll discover is if you lean into that and you understand it and remember it, the next course will be easier for you. This next unit will be easier for you. And then after 202, you start growing with that and you go into like pathology. A lot of that stuff is building block foundation. And you don't have to relearn it every time. So this motif of having myelinated and unmyelinated fibers, packaging them in a bundle, wrapping it with a perineurium, having those individual fascicles in a bundle. Now you need to perfuse it with a blood supply. You wrap it with an epineurium. We saw the same motif with what tissue in the past? With bone. And I promise you we're going to see it again next week when we look at muscle. Okay? Same motif. It works. Why would you design it a whole new way. So think about it. Just a simple example in the body. We see from one organism to another, species, genes, a lot of sharing going on. If it works, why wouldn't you use it again and again and again? Take the wheel, for example. We've had a lot of development just in the automotive industry in about 100 years. The wheel is still what shape? Round. Whether it's electric or a carbon, footprint that's huge off of a fossil fuel vehicle, still a round wheel, still a round tire. There's no triangular, octagon. We're not trying to, get real creative with a wheel, because guess what? It works. Same thing here. Why isn't this square? Why isn't it triangular? Well, it's actually very efficient to make it circular. And you get this diffusion distance that radiates out from those blood supply. So you're going to see these kinds. So if you lean into the stuff, it becomes a little bit more easy, because you're like, oh, I've seen that before. If that's not a nerve, maybe it's muscle, maybe it's bone, right? And now you only have 3 choices when you're looking at histology, or when you're looking at imaging, or you're looking at a CT scan or an MRI. So if you learn some of these little tricks and tips, I think they're going to serve you in the future. We also saw this. We saw that these spinal tracts, right? We saw this in the last unit. These spinal tracts, they will decussate. As you move information up, it decussates at what level in the spinal cord? Or in the central nervous system, I should say. Where does sensory information from the patient's right side come up and decussate or cross over? At the level of the medulla. Do you remember that? What about when it comes down with efferent pathways? These are actually called ascending tracts, or afferent with an A. These are descending tracts called efferent with an E. Where does it decussate when it comes down? This actually could have been a question on the last unit. So hopefully this is making sense and you're just being shy today. If it's not making sense and you're kind of saying, I don't think we saw that before, I promise you we talked about this in the last unit. So make sure you know it for the next exam. That's a pretty big hint, right? Where does it decussate as you go efferent pathways or motor pathways down from the brain? Where does it cross over? It's not a trick question. Anybody? The answer is like right on that slide. Yeah. It's also at the level of the medulla. So one of your colleagues actually asked me the question, and they stumped me. They said, you guys asked some really good questions, actually. And they said, well, Dr. Keller, why does it cross over? What's the point? And I didn't know the answer. So actually, we looked it up. And the best theory, although it's a theory, is evolutionarily when sensory information was coming in on a ventral aspect, because we were on our bellies, or our predecessors were on our bellies, with a central nervous system that we borrowed the motif from. At some point, our predecessors moved to a erect pathway where ventral information wasn't as important. And so that's when the nervous system switched to dorsal aspect. And so that's the best prevailing theory right now, that happened at the level of the medulla. But it's just a theory. Nobody actually knows, because nobody was around when that happened, right? So, great question. The reason I bring it up is hopefully it'll remind you of where this decussation takes place, at the level of the medulla. Really important, because clinically, as you move on, patients that have trauma at the level of the medulla oblongata have right-left-sided confusion. Okay? They get sensations from one side thinking it's the other side. They have gait issues because they can't locomotor correctly with the right versus the left side, with a lesion at the level of the medulla. Question? Someone could be born, that's the question, is that only brain injury? So it could be traumatic brain injury, it could be a stroke at the level of the brainstem, which is usually fatal because it controls things like heart rate and breathing. It could be a tumor, or it could be a genetic predisposition that someone's born with. But that could actually be, a minor outcome if somebody is born with a medulla issue. We also looked in the last unit, some review, we also looked at how these tracts are organized. And we looked at tracts that are ascending tracts, or what we refer to as afferent or efferent. Afferent with an A, very good. And afferent with an A are sensory inputs that go up to the brain, bringing information from the dorsal aspect upwards. Efferent tracts, or descending tracts with an E, motor tracts coming down, utilizing more ventral pathways, coming out ventral root horn. So if we had questions, which we didn't on the last exam, but if we had them on the next exam, that was asking about the movement of these neurons up or down, you'd actually be able to answer those questions, correct? We also referred to these plexi. We talked about a plexus, which is a network of nerves, or it could be blood vessels, but in our case it's nerves, a network of nerves that are in one spatial organization. And so the cervical plexus and the brachial plexus are coming off of the spine at the level of the spinal cord between C1 to C8. We have our lumbar plexus, our sacral plexus coming off L1 to L5 and then S1 to S5. And then we said we had thoracic nerves, but no plexi. So there are nerves in the thoracic, but they're not as organized into these giant bundles. And we also talked last unit about how at the level of the brachial plexus, because the sensory information from, say, the heart is minimal or non-existent for the most part. And so the left brachial plexus is what sends the information during a heart attack that there's pain in the chest. And that's why patients have left shooting pain down the arm. Questions over those slides that are slight review, but just trying to wind us up to what we're talking about today. We covered some of these things like reflexes, and we talked about a couple of examples. I'm going to refresh our memory on some of these. Again, we're at the autonomic nervous system. So we're down here within the peripheral nervous system at the level of the autonomic nervous system. We actually had this particular question in class that we went over. So I want to pose it again as we refresh this information. Think afferent and efferent. Think ascending and descending tracts. Think dorsal and ventral as you look at this question. Left postcentral gyrus receives information about the texture of a fabric that you're touching. Along which spinal nerve did the signal enter the spinal cord on its way to the brain? So is it going up or down? It's going up. Is it an ascending or descending track? It's an ascending track. Is it afferent or is it efferent? It's afferent. You guys are rocking it today. Now, if it's coming up, is it coming from the dorsal or the ventral aspect? Dorsal. If it was the left postcentral gyrus, where's that located? It's in the brain. Okay, that's all I wanted to know. Right? Sorry, I pointed this side. It's actually here. Left postcentral gyrus, my left, right? Correct? If it's hitting the left postcentral gyrus, where did it originate from? The right side, because it decussates where? I think you're understanding this. At the medulla. So where would this information be coming from? This is anatomical position. So if this is anatomical position, this is the Anterior or posterior? Anterior, posterior is here, or ventral and dorsal. You understand those terms are interchangeable, right? This was like early 201 lab. Ventral is anterior. Ventral is from when organisms are actually facing the ground. Dorsal is posterior, like the dorsal fin on a shark. Okay, so now you stand up. This is still ventral, but it's anterior. So it would be fine. Don't get confused if I ask the question, is it ventral or anterior? And you would say, yes, it's both. So now with that information, anatomical position through this slice. You understand this slice is a transverse slice. Okay? Where is this information coming up? A, B, C, or D? A. Everybody understand why it's A? A is the posterior or the dorsal aspect, A or C. That's where sensory information comes in. And because it decussates at the medulla and it went to the left side, it crossed over from the right, from the patient's right. This is the patient's right, A or B. You all follow that? Okay. I know it's a little confusing. That's why I wanted to go over it. I felt like in the last unit, some of this might not have sunk in. And that's why there weren't questions on the last exam over this material. Will there be questions potentially on the next exam over this material? Yes. That's why I'm taking the time to go over it. We looked at aspects of a reflex. And here is what I want you to take away from aspects of a reflex. There are 4 main characteristics of a reflex. This would be 4 things that would be really important to write down for when you study. Anybody want to give them to me? We went over these last time. Anybody have some ideas of what these 4 things might be? Characteristics of a reflex? It's always the same every time. There's a word for that. We would call it stereotypical. Okay? And in this case, it's okay to stereotype. Perfect. That's number 1. Second, it is involuntary. Well done. There's 2 more. Back here. It needs stimulation. In other words, it needs sensory input. 4, it's quick or rapid, not slow. 4 characteristics of a reflex. Now, we walked through a couple examples of a reflex. Like, we talked about a muscle spindle. We talked about a Golgi tendon. And those are examples of reflexes. And that's what I want you to take away from that. We went through the details last unit, so I'm not going to bog you down with those details. If I ask questions about muscle spindle or Golgi tendon in the next exam, those are examples of reflexes. And the characteristic that I'd like you to remember about each of them is that the muscle spindle is detecting a change in muscle length. The reflex is based upon length changes. Does anybody remember the Golgi tendon? What was the information that the Golgi tendon was responding to? It wasn't length. It was tension. And these are 2 examples of organs, structures that help protect you so you don't tear something. And if you think about a reflex, like it's a protective mechanism, right? So these are examples. 1 responds to changes in muscle length. That's the muscle spindle, where you get that sensation of, ooh, that's a little too far. I think I might have pushed it. You know, like you're running. My third daughter's a gymnast, and she had state championships this weekend. And there's this one young lady in her floor routine hyperextended her knee, and I'm sitting right like in the front row, and our eyes locked, and I was like, oh. And then after that, I think she was like, oh. I shouldn't have responded. You know what I mean? I should have been like, you're good. But she was like 2 gymnasts before my daughter, and she just kind of like buckled her leg, and she knew right away that she had hyperextended it, and in the next event it was wrapped and there was an ice bag and all that. The muscle spindle and the Golgi tendon are giving you length feedback to tell you, ooh, that was too far, something's probably going to hurt. Or tension, if it's the Golgi tendon. That's correct.
You said that with like part of the autonomic nervous system is that you can override things like the urination thing. Could you learn to override a reflex at all?
Yeah. So the question is, it's a great question. And we'll show a video. I'll show a video of mituration reflex, which is the urination reflex, which probably 100% of us have overridden. Okay, I'm guessing we're all potty trained. So, well done, right? So the question was, these are autonomic responses, but can you override them? And the answer is yes, you can. Can you do that in training? Yeah. I know we have a couple of elite athletes in this room, and I will say, student athletes, that's a tough job. You got 2 masters. And you know what it is to push the envelope. Some of you are recreationally active, but you compete at a high level. And there are situations where you're training and you're trying to shave a second, 2 seconds, fractions of seconds. Or you're trying to hone in and get faster in this event or this activity or this segment. You watch film. Your coach goes over your form, gives you feedback. That feedback turns into conscious training, which overrides lots of reflexes. Okay? If you've ever overtrained to a point where it hurt, your reflexes were being overridden because our reflexes tell us to stop, not to go harder. Right? Great questions. All right, along those lines, again, a lot of this information we already covered in those slides. I'm trying to highlight the stuff, the salient points that I do want you to write down and remember in the situation that a test question shows up on exam 4. Let's carry this forward into reflexes, this is all new material now. And that was our segue from old material in Unit 1 to prior material in Unit 3 that we covered at the day of the review session before the exam. And I chose not to ask questions on the exam because the new material happened on a Monday and the exam was on a Wednesday. Now let's move into some of these autonomic or visceral reflexes that I think might resonate a little bit more for you. The first one up is called this baroreceptor reflex. And these autonomic reflexes, true to our list that we just described of the 4 things that are common about a reflex in general, we get into an autonomic reflex at the level of the viscera. We're going to start talking about things like heart pressure. Same thing, unconscious, autonomic, stereotypical. However, here they're a little bit slower. That's the difference. At the level of the viscera, it doesn't have to happen immediately because it's not interacting with this outside environment, like, say, for example, the muscle spindle, the Golgi tendon, where you're getting real-time feedback about your position, your length of your muscle, which is another word for position, or tension, like in the Golgi tendon. Muscle spindle length, Golgi tendon tension. Here we're getting information about something that's happening internal. And we don't need to immediately change it. In fact, it's hard to because you're talking about a pump that's pumping blood. So here they're going to be a little slower on these autonomic visceral reflexes. And that's one of our big differences. So we've got some examples that are being shown in this loop that we're going to walk through. So we've got baroreceptors, and a lot of times in textbooks, these baroreceptors are shown to be in the aortic arch, right? These aortic arch. There are some populations of baroreceptors. That's a word for pressure receptor. Baro, like the barometer or the barometric pressure, is air pressure. It's a weather measurable item that we pay attention to see when it goes higher or lower, to see when a storm's coming in. So a baroreceptor is just a pressure sensor that's found in the aortic arch, so you can say they are here, but a lot of them are found in the common carotid artery, which runs up to the head. And these baroreceptors, they'll sense an increase in blood pressure. This glossopharyngeal nerve will send a signal to the medulla, and there's an interneuron that will send down the vagus nerve inhibitory signals to the sinoatrial node, which is where the pacemaker is in the heart, the natural pacemaker. And this will actually slow down heart rate. So you regulate your pressure with this feedback loop. Is this a positive or negative feedback loop? I'm looking for some new hands. Positive or negative feedback loop? It's okay if you're sort of halfway there. Yes, sir. Negative feedback loop. Why is it a negative feedback loop? So it senses high blood pressure. The response is in the opposite direction, so it slows down the heart. Positive feedback loop would be it gets a stimulus, it ramps it up. That's a review concept from Unit 1, if you remember. Do you remember that? Kinda? So it's coming back, right? So this is an example of a negative feedback loop. This is important. You have high blood pressure, you need to slow it down. How do you do that? Well, you put sensors that go up to the brain, sensors in the aortic arch. This textbook only shows them in the common carotid artery, but they do exist here. And the reason they exist in both locations is this is the main flow of blood to the body. This is the main flow of blood to the head. So you kind of need to measure both. You with me? Glossopharyngeal nerve transmits to the medulla oblongata, regulates heart rate, sends a signal to the vagus nerve, slow things down. Negative feedback loop example. But a really good example of how this operates. Now I want to show you this little video.
Baroreflex, or baroreceptor reflex, is one of the mechanisms the body uses to maintain stable blood pressure levels, or homeostasis. Baroreflex is a rapid negative feedback loop in which an elevated blood pressure causes heart rate and hence blood pressure to decrease. Reversely, a decrease in blood pressure leads to an increased heart rate, returning blood pressure to normal levels. The reflex starts with specialized neurons called baroreceptors. These are stretch receptors located in the wall of the aortic arch and carotid sinus.
See, that one says it's in both, right?
Stretches the wall of the aorta and carotid arteries, causing baroreceptors to fire action potentials at a higher than normal rate. These increased activities are sent via the vagus and glossopharyngeal nerves to the nucleus of the tractus solitarius, the NTS, in the brainstem. In response to increased baroreceptor impulses, the NTS activates the parasympathetic system, the PSNS, and inhibits the sympathetic system, the SNS. As the PSNS and SNS have opposing effects on blood pressures, PSNS activation and SNS inhibition work together in the same direction to maximize blood pressure reduction. Parasympathetic stimulation decreases heart rate by releasing acetylcholine, which acts on the pacemaker cells of the SA node. Inhibition of the sympathetic division decreases heart rate, stroke volume, and at the same time causes vasodilation of blood vessels. Together, these events rapidly bring down blood pressure levels back to normal.
Okay, a lot happening there. A little robotic, her voice, right? But you could watch it again, see if you understand what's happening. We've got two cranial nerves that we're introducing here, right? In the lab, you'll cover them in more detail. We've got a neurotransmitter of acetylcholine. We've got the parasympathetic system. We've got the sympathetic system. There's a lot happening that you're integrating here. And guess what? We're not even in cardiovascular physiology That's next semester in 202. And you'll unpack this more. But this is an example that I chose to put in 201 because it's a reflex, and it'll help you build when you go to the cardiovascular system in 202, because you'll think through, oh, that's right, I do remember that this baroreceptor reflex is just a simple reflex, right? And we've got information going into the autonomic nervous system, and it's a negative feedback loop. We have too high of blood pressure measured at the level of the aortic arch and the carotid artery going to the brain, and we need to slow things down. And we know that acetylcholine being released here will stimulate the parasympathetic system to lower heart rate. It also inhibits the sympathetic nervous system. So you're turning off one that ramps things up, and you're turning on the other that slows things down. And then the last thing, if you caught it, was vasodilation. So if you need to lower pressure, let's put it the opposite way. If you have a garden hose and you turn on the water, and the pressure's too low and you need to immediately raise the pressure so you can spray your sibling, what do? Put your thumb over the end and shrink the size of the opening. That's essentially vasoconstriction. What you do here is you vasodilate your vessels, which is the opposite. It's like taking your thumb off of the hose, and now you lower pressure. Make sense? This is just your heart doing multiple things all at the same time to try to bring back blood pressure to a normal level. Questions over that?
What about in pregnancy? Because I know in pregnancy, blood pressure rises.
In pregnancy, women tend to be a little bit more hypertensive. And the reason for that is because you're trying to get enough pressure at the level of the maternal-fetal exchange, where fetal hemoglobin actually has a higher affinity for for oxygen than maternal hemoglobin, so it'll strip off the oxygen. But you need a pressure gradient in order to deliver blood to the baby. And so a lot of the hormones that happen in pregnancy actually alter, well, a lot of things in the woman's body, but one of them is overriding and allowing the female mom to be a little bit more hypertensive and have higher blood pressure and blood flow. So just like a little case study, but like my wife has low blood pressure. She's always cold. And one thing she loved about being pregnant was she was warm, and her blood pressure was like almost normal. And it's because of the pregnancy hormones that actually help to raise blood pressure and keep the mom slightly hypertensive. Not in a dangerous level, but, and again, it's only for 9 months. Other questions? Okay. All right, so the reflex arc, we've got a couple of different pieces of the equation or of the loop that I want you to be thinking about. We have receptors. Tell me, what are the receptors in this baroreceptor response or reflex? What are the receptors? They're the baroreceptors. They're the pressure receptors. Duh, Keller. But I want you to connect the dots. The baroreceptors are found where? You tell me. Carotid artery and the aortic arch. What do these receptors detect? Tension in the form of a pressure. Afferent neurons. Where are the afferent neurons? And why are they considered afferent? Why are they defined as afferent? Okay, so which one are they? What are the afferent neurons in this example? I agree with your definition. They send information from the heart to the brain. Here they're going to the medulla, but it's part of the brain. Glossopharyngeal, which is actually what? Cranial nerve 9. Okay, that's what it does. You memorize in lab all these cranial nerves. Now you can kind of put some physiology to what they do. Perfect. That's the afferent neuron. A, taking it to sensory, taking it to the brain. Now we got an interneuron, which is pretty self-explanatory. That's that little short neuron right here that stays in the central nervous system. But it actually innervates onto an efferent neuron with an E. Is that sensory or is that motor? It's motor, exactly. What's the motor? What's it going to do? And what target tissue does it innervate onto? It's a muscle. We affectionately refer to that muscle as the heart. Yes, not a trick question. So does that make sense that it's efferent going to a motor response to a muscle that's myocardium, that's heart? Causes an effect. The effector is what? What's the ultimate effector? Yeah, the SA node, which is part of the heart. Okay? And what's the result? Lower heart rate. What is, in this diagram, what's the efferent neuron? It's not the glossopharyngeal. It's the vagus nerve, which is what? Cranial nerve 10. Make sense? Hopefully some of this information is kind of starting to come together. You're synthesizing stuff that we had in the beginning of the semester, that you've had in lab, dissections that you're doing this week, stuff we learned in the last unit. We're building on this reflex, and now you've got a real-world example that's maybe a little bit more interesting, which is how do you manage raising and lowering heart rate? Yes? No, I'll probably give both of them to you on the exam. I think in lab you got to know both. But in lecture, I would like you to know glossopharyngeal and vagus cranial nerves because we have a physiology example. But I won't trick you. If I say vagus, I'll probably put 10 in parentheses. If I say glossopharyngeal, I'll put 9 in parentheses, just so you're not confused. Okay? If you're on the floor in the hospital and you need to look that up, you can Google that super fast if you get them mixed up. Okay? All right, next one. Let's talk through mituration reflex. Another video.
Neural control of urination, micturition reflex. When the bladder is full, stretch receptors in the wall of the bladder send nerve impulses to the sacral region of the spinal cord. By way of a parasympathetic response, signals return to the bladder and stimulate contraction of the muscle of the bladder and relaxation of the internal urethral sphincter. This part of the reflex is involuntary and is predominant in infants and young children. As the central nervous system matures, it acquires voluntary control over the external urethral sphincter. Urination is controlled mainly by the micturition center in the pons. This center receives sensory signals from the bladder and communicates with the cortex about the appropriateness of urinating at the moment. At times when it's not convenient to urinate, the center sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder to contract and the sphincters to open to let the urine out.
Make sense? So the thing I like about this example is it's simple, just like the heart. We can all relate to it. You'll see this in your patients. Is it any surprise in pediatric patients, very, very young, this reflex is hard to control? And in geriatric patients, very, very old, this reflex is also hard to control. Okay? So it's kind of a cycle that we go through. We kind of start in diapers and we sort of go out in diapers. Right? But it brings a lot of physiology to this normal reflex from just a pure physiology standpoint is getting rid of waste. We override that by our conscious centers to say it's not convenient. Now, what's happening at nighttime when we're sleeping? Where clearly you train this enough, you're not totally out. You're still controlling some conscious activities if you're not wet in the bed. Now, there are patients that many of you will have, unfortunately, that are totally out. Those will be patients in comas. Those will be patients that are on support, whether it's this system or that system, heart-lung machines. And this won't be operational. Questions over baroreceptor reflex or mituration reflex? Is that making sense? Okay, so now let's break down, in the remaining time that we have today, let's break down these different divisions of the autonomic nervous system. And then we're going to talk about the enteric nervous system that I brought up in the very beginning of lecture. Essentially, we've got sympathetic nervous system, parasympathetic nervous system. And contrary to popular belief, it's not all or nothing. Oftentimes, both are in operation at some basal level. So let's go back to the heart example. Your heart's resting organ heart rate is about 100 beats a minute. So if you took a heart out of the chest cavity, set it for cardiac transplant, you harvested it, it was still beating, you pulled it out of the chest cavity, it's completely deinnervated, it would beat either on the surgical table or in your gloved hands at 100 beats a minute. That's the rate at which the SA node will fire. That's the pacemaker. It's like a metronome for those of you that are musicians. That's what the heart normally operates at. Many of you have a resting heart rate that's significantly lower than that. Might be at 80, might be at 60, might be at 40. The more elite the athlete, usually the lower the resting heart rate is. So why is it so low? Because the parasympathetic system is slowing it down from 100 to, say, 60. The moment you start to exercise, the first thing that happens is parasympathetic innervation is removed, and the heart goes from 60 to 100 really fast because you took off the brake. Then you push the accelerator, which is the sympathetic nervous system, and you go from 100 to basically 220 minus your age. Okay, so if you're 20 years old, your max heart rate is about 200, plus or minus 10. That's the physiology literature. And elite athletes typically have a maximum heart rate that would be 220 minus their age. So say in the 20-year-old fit elite athlete, they might be hitting 220 as a max heart rate. Okay? So the more elite you become, you push the envelope in both directions, resting as well as max. Okay, so sympathetic, fight, flight, physical activities, increases heart rate, blood pressure, breathing, blood glucose levels, skeletal muscle perfusion. You put more blood flow into your active muscles. It's a small blank, I know. There's a lot of things that go in that small blank. Sympathetic nervous system increases heart rate, blood pressure, blood glucose levels. That's your energy. That's your sugar source to make ATP. Skeletal muscle perfusion. And it decreases blood perfusion to the skin and the digestive tract. This is the reason if you eat a big meal or you eat the wrong meal before an elite performance, you get cramps or you'll throw up. Because you shunt blood away from your gut and you don't digest the meal and you push it to your exercising muscles. Parasympathetic, these are calming activities. We call it feed, breed, defecate, calming activities. It reduces energy expenditures, and it supervises or oversees, helps to facilitate digestion and waste elimination. So now you're shunting blood to the gut to try to process the meal. Now, when you exercise, it's not that you shunt all the blood from your gut and all of a sudden your hamburger is just sitting in your stomach. It's not an all or nothing thing. You know, it might be 60-40 or 80-20 or 90-10. But you only have a certain amount of blood flow, and so you're going to control it, and you'll see that in 202 when you get into the cardiovascular section. We'll talk about it again in pathology. You have a limited blood supply, so you'll move it around your body where you need it, if everything's operationally happening the way it should in healthy individuals. And this concept of autonomic tone, that's just the background rate of activity that we have in any tissue at any given time. So take the heart example. The autonomic tone at rest is you have a parasympathetic tone that lowers heart rate. And sympathetic activity is dismissed until it's called on and you need to exercise. Now, the sympathetic nervous system is made up of a couple of different divisions. We've got a thoracolumbar division, and then the parasympathetic is made up of the craniosacral. And this just refers to kind of where these nerves take off from the spinal cord, from the central nervous system. So the sympathetic nervous system, fight or flight, raising heart rate, raising blood pressure, raising breathing, putting more glucose in your blood, comes off of the thoracolumbar. So it's going to come off of areas that are associated with the thoracic portion of the spinal cord as well as the lumbar portion of the spinal cord. And it utilizes this organ known as the adrenal medulla. And this adrenal medulla is a structure that is a modified sympathetic ganglion. You understand what the word sympathetic means? What in the world is a ganglion? That is just a fancy term for a collection or a mass of nerve cell bodies. So these are cell bodies of nerves that make up the adrenal medulla. Its role is to secrete epinephrine and norepinephrine. Epinephrine is also referred to as adrenaline, and norepinephrine is referred to as noradrenaline. And you can remember this because it's the sympathetic nervous system. It raises your heart rate. It gives you that adrenaline surge, which we've all talked about, which is accurate. And so that'll help you remember what the thoracolumbar division, that's just where these nerves come off. They come off the thorax and the lumbar areas. In contrast, one second, Kai, when we look at, here, let me just talk about this. So here's our spinal cord. Here we've got a sympathetic preganglionic neuron that's going to innervate into the adrenal medulla. This is what's going to release epinephrine and norepinephrine into the circulation. So it goes into the circulation, it circulates around the body, it binds to its receptors that are found in all sorts of different areas. Some of those receptors are on your heart and your lungs, and this is like there's a fire alarm in the middle of the night, or there's a smoke alarm that goes off in the middle of the night, and you wake up, and all of a sudden you're panicking, and it's a couple of seconds later you can feel your heart start to race. You came out of a deep sleep, and now your heart's racing. And that time, that delay in time between when you were asleep and resting heart rate, you sit up, and then it's like coming out of your chest. It's because this had to circulate all the way around to your heart in order to find the receptors to trigger an increase in heart rate. Kai?
Why do we have two names for adrenaline? Why don't we just call it epinephrine or
Great question. Why have two names for adrenaline? Adrenaline is epinephrine. Norepinephrine is noradrenaline. They are two different molecules. Epinephrine is more physiologically active, but norepinephrine is like the cheap version. It's easier to make. So your body has a redundancy. So let me pause here. This would be a great place to kind of point out not just similarities in architectural motifs in biology, but redundancy. When you see a system, a physiology system, and there are redundant or backup systems, a couple of things that do the same thing, that should tell you that must be really important. And so this underscores in physiology, we would say, this is an underscore of how important epinephrine and norepinephrine are. And from a survival standpoint, if you think about it, do you need to be able to run away from threats? Yeah, you betcha. And so, of course, you're going to have this redundancy in the system.
Would you say epinephrine and norepinephrine can be kind of translated to like myelinated and unmyelinated axons, whereas like myelinated are expensive biologically to make, but they're faster and kind of better.
Yeah, I could see, I didn't know where you're going with that when you're first starting it, but yeah, I would agree. I mean, the comparisons just philosophically to myelin and unmyelinated. Can you get away with one versus the other? Is one more expensive to make? Yes. Do they do similar things? Yeah. Do one of them have an advantage over the other? Yes. And so your body's looking at where do I use one versus the other?
So if you go into anaphylaxis, you use epinephrine to kind of get your body out of that. So what would happen if you use norepinephrine instead?
Same thing. Yeah. So like, patients, if you're an EMT, you're a paramedic, you're working the ED, patient comes codes, you'll deliver epinephrine to the patient stat as quickly as you can to try to revive the patient. If you use norepinephrine, you'd get the same response. You would just need a larger dose. So you can get away with a smaller dose, smaller concentration because it's more biologically active. And that's why, on all the movies, they don't call for norepinephrine, right? Give me some norepi. They call it epi, right? Yeah, so the question is longer term anxiety, something that's not immediate or urgent. If you have some anxiety over something and it's lasting for hours or days, that might be more of a norepinephrine response that's being circulated around your bloodstream. So for exam 4, let's work on the parasympathetic system and just kind of calm things down a little bit, right? Great questions. In contrast, parasympathetic nervous system, it's referred to as the cranial sacral. Why? Anybody want to guess why it's called the cranial sacral? Where do you think the nerves come off of the spinal cord? Off of the brainstem, essentially, and off of the sacral plexus. So you can kind of see we've got ocular motor neuron, 3. We got the facial nerve, 7. The glossopharyngeal nerve, which is 9. And we've got the vagus nerve, which is 10. We've already talked about that one. And then down here, we actually have these splanchnic hypogastrics, that perfuse the genitalia. So, parasympathetic nervous system. Cranial sacral leaves the brainstem by 4 different cranial nerves. 1, 2, 3, and 4. We got ocular motor, facial, glossopharyngeal, and vagus. And then down here, we've got the pelvic splanchnic areas and the hypogastrics that perfuse the sexual organs. enteric system that I want to touch on. So this enteric system is both sympathetic as well as parasympathetic. It operates really on its own, and it's a subdivision of this autonomic nervous system that controls the gastrointestinal system, or the gut. And because this is so important to our survival, being able to pull nutrition out of what we eat, we have our own nervous system that operates this independently of us. And this is why you can actually perfuse somebody that, is not conscious. You can feed them through a tube, or you can feed them IV, and their enteric nervous system is operational. They don't have to be awake. They don't have to be conscious. It actually regulates motility and secretion of all the digestive enzymes necessary to process our meals. You'll look at the enteric nervous system and digestion next semester in 202 in a lot more detail when you go through GI physiology. So, anatomy. Let's look at anatomy of the sympathetic nervous system as well as the parasympathetic nervous system. And then we're just going to conclude on a comparison chart of somatic versus autonomic. So, the sympathetic nervous system is really organized utilizing these pathways, where we've got nerves extending out of the ventral aspect, and they're coming down either a sympathetic nerve, a spinal nerve, or a splanchnic nerve. And then they're out into the periphery. This is basically how we distribute the signal out this ventral or anterior root horn to give ourselves this widespread effect as we're trying to dissipate the signal. In contrast, if we look at the parasympathetic nervous system, we actually have long presynaptic axons that travel to terminal ganglia. Remember, a ganglion is just a collection of nerve cells, nerve cell bodies, and it's a little bit more selective in its stimulation. So if you look at parasympathetic activity, again, cranial sacral, cranial nerves, these four, as well as the sacrum, we have these ganglion that are out in the periphery, where these nerves actually go to this collection of cell bodies. Celiac ganglion, there's the otic ganglion, submandibular ganglion, ciliary ganglion, and the pteropalatine ganglion. And this is the root or the motif that's being used, whether it's sympathetic or parasympathetic in this example. We'll get into more of these types of motifs on Wednesday, but I want to set the stage. And we'll start out with the question that I posed on the prior slide. So we'll start on that activity on Wednesday. But what I want you to look at is, here's a somatic efferent innervation with a myelinated fiber to a somatic effector cell. This is an autonomic efferent innervation, has an autonomic ganglion. You've got acetylcholine here. Over here you have acetylcholine or norepinephrine. Now when we looked at acetylcholine on the baroreceptor reflex, what did the release of acetylcholine do? It decreased heart rate. If you release norepinephrine onto the heart, what would it do? It'll increase heart rate. So here is an example of autonomic innervation where you can use the same roadway, the same wiring, but over here at the target organ, you can get different responses based upon what neurotransmitter you release. And that answers the question is, why do we even have neurotransmitters? It gives you a level of control. Instead of having two different wirings, you can use one wiring with two different neurotransmitters. You with me? So it's more efficient. So if we compare and contrast this chart, which is a good chart for you to study, I think. This is from a different textbook. This is obviously out of a chapter 15.1, which is not in your textbook. You've got somatic features in the second column, and then you have autonomic features in the far right column. So if we look at somatic versus autonomic, the effectors of the somatic system, think of somatic as being like body or under conscious control. And you might write that down next to somatic. Skeletal muscle, it's usually voluntary. One nerve fiber from the central nervous system to the effector organ, no ganglia. You use acetylcholine, it's always excitatory. If you cut the nerve, you get what's called flaccid paralysis. The muscle is non-responsive. In contrast, so that's somatic, that's this top diagram. The bottom diagram is autonomic. It's automatic. Those are glands, smooth muscle, cardiac muscle, kind of where we've been today. It's usually involuntary. You can override it. We talked about the maturation reflex. Can you control your heart rate? Yes. Can elite athletes in the middle of an event lower their heart rate? Yes. If they train. But it's usually involuntary. Two nerve fibers from the central nervous system to an effector organ, there's a synapse at a ganglion. You have acetylcholine and norepinephrine as a neurotransmitter choice. It could be excitatory or inhibitory. If you cut the nerve, you have denervation hypersensitivity. That's this pathway. Make sense? So this table tells you features of this pathway. This table tells you features of the top pathway. And when we come back on Wednesday, this is the slide that we'll start with. I want you to compare and contrast somatic reflex arc, like Golgi tendon, muscle spindle, visceral reflex arc, autonomic. Talk about the differences. Compare and contrast. You with me? All right, y'all have a great evening. I'll see you on Wednesday. Hopefully it'll be less windy.